Good afternoon, everybody. It's Monday for our weekly Instagram chat. Give me 1 second, and I'm all with you. For our weekly Instagram chat, today's topic is fertility preservation, otherwise known as egg freezing 101, for those of us who remember those fond college days of intro classes. The first question, obviously, is what is egg freezing and what is fertility preservation? As we know, as a woman ages, there is less ovarian reserve in the ovary. There are less number of eggs, and the eggs that are present don't respond as well to stimulation. So that as one goes through life, the total number of potentially available eggs that are present in a woman's ovary and the ability to harvest those eggs for use in vitro fertilization goes down as time goes on. So there's no way to turn back a biologic clock. The only thing that one can do is to sort of freeze a picture of what it looks like now, to take a snapshot of what the ovary is doing now and saying, how do we take this and make this available in the future to preserve fertility? And you can preserve fertility either by freezing embryos, freezing eggs, or freezing sperm. In women, particularly ones that don't have a partner that they're absolutely sure that they want to get pregnant with down the road, freezing eggs is the most logical choice. Whereas if you have a partner in a stable relationship and you know you're going to have a child together at some point down the road, then freezing an embryo is an alternative and has some advantages potentially. There are two different types of reasons why we would cryopreserve eggs, basically, or egg freezing. And you can break these down into medical reasons why we would want to do it in a patient, or social reasons. Medical reasons would include somebody that's being treated for a cancer, let's say, where they know they're going to be put on treatment that is going to have an adverse effect on their ovary, whether the person's 19 years old as an adolescent with a leukemia, or whether it's somebody in their 30s with breast cancer who needs chemotherapy, and the effect of that by past experience is that it may have a very adverse effect on the quality and quantity of eggs that remain after that treatment. So in those cases, that's a medical reason why people should consider freezing eggs. And certainly most of the oncology groups now think of fertility preservation in any reproductive age woman before they start treatment. Social reasons are much more related to just personal needs. If somebody is getting older and they haven't found Mr. Right, or for whatever reasons just don't want to have a baby right now, whether this is because they haven't found the right partner, or even because of COVID or other issues that exist and they're afraid to get pregnant at present time, this is an option for couples or individuals to preserve their fertility. If you're looking at who's a good candidate to freeze eggs and when to do it, anyone who has a good reason to preserve their fertility, they want to get pregnant later but not now, is a good candidate. And if you took that and extrapolated it to the general population, that would pretty much fit any woman under the age of 45, basically. The issue is that the younger you are when you cryopreserve your eggs, the more eggs you're going to get with less fertility drugs being used, and the better those eggs are going to work once you use them, if you need to use them. The dilemma comes in that if you freeze everybody's eggs when they're 22 years old, most people won't need those eggs to get pregnant because they'll get pregnant on their own over the next 15 years of their reproductive life. But if you wait till somebody's 41 and 42 to try and preserve fertility by egg freezing, it's not as cost effective because you don't get as good a response of the ovary. So you're better off doing it sooner than later. Obviously, in patients that are being treated with chemotherapy or radiation therapy, or have a history of surgeries, or a history of an ovary being removed, and they have one ovary left, and they're worried about that ovary being compromised for a similar reason down the road, and they just want that added security. Those groups of patients, you got to do it now rather than later. A lot of patients come in and they ask, how's my fertility? You know, how can I tell if I'm going to have a problem or not? How do I gauge it somehow, or put some quantitative assessment to it? And so you can ask a series of questions to try and answer that. The first is, how old are you? And as I alluded to, the younger, the better. 37 is better than 42, 32 is better than 37, and 28 is a whole lot better than 30, 32, 35. So the younger, the better. In general, the sweet spot for egg freezing is probably between age 30 and 35, because in this age range, most people's ovaries are still fairly responsive to fertility drugs. The embryos, when they're formed down the road, if you need to use the eggs, work pretty well. And you tend to be able to get a good response with less doses of fertility drugs. And if you haven't gotten pregnant by that point, that's a good time to consider freezing eggs. My daughter's 28, and I've been telling her for years, Dad's freezing her eggs at 30, and she's slowly warming up to the idea. The biggest problem we have is patients come in, they want to know what their fertility is, and then we go, okay, we ask them how old they are, we do some blood tests for anti-Müllerian hormone, or AMH level. We measure some hormones called FSH and estrogen, and we can look at antral follicle counts by ultrasound on the ovary, and putting those four things together, you can get an idea of, you know, where the patient is. Sometimes they'll all be consistent with each other, and sometimes we may say one test to be okay and one test not okay, and we'll get a little bit of a mixed signal with that. The mistake is using the answer to really answer the question, should I freeze my eggs? Because if you're waiting till your ovarian reserve is already low and then you freeze your eggs, it's not the most optimal time to do it. The most optimal time to do it is before you lose ovarian reserve, because that's when you're going to get the best response out of the ovary. It's kind of like, buying car insurance only really works if you buy it before you get in a car accident, not after you had the accident. So it's certainly better doing it even with low ovarian reserve over not doing it at all, because there's no other option. If you don't freeze eggs, even with low ovarian reserve, then the concern is that, some eggs, even though it's less optimal number, are going to work better than no eggs. So it becomes a dilemma with that. And so the take-home message, if we have the opportunity to cryopreserve eggs sooner, that's the better time to do it. You can cryopreserve eggs at any age. It's just going to work better if we do it sooner rather than later. And the object is to get as many eggs as possible to cryopreserve. And sometimes you can achieve an adequate number with one egg retrieval, particularly in somebody in early 30s. And sometimes patients may need more than one cycle of egg retrieval in order to get that to happen. So what are we doing to freeze the eggs? How do we get the eggs and stuff? We're basically doing in vitro fertilization. We're doing the first part of the process now and saving the second part for a later date if you need it. So the first part of the process is to stimulate the ovary with fertility drugs to make multiple eggs. As you know, normally you make one egg in a cycle. You ovulate one, and most pregnancies, if they're going to occur, are going to be singleton pregnancies. Occasionally you'll get a twin pregnancy. Most of those will be from non-identical twins from two eggs getting out. Some of them might be from a single embryo splitting. But in general, you tend to produce one egg in a cycle that's going to ovulate. And if we retrieve one egg at a time, this wouldn't be a very efficient system. So we use injectable fertility drugs with the idea that we're going to stimulate the ovary to try and produce ideally 15 or 20 eggs in a cycle. And depending on the patient's age and ovarian responsiveness, we can adjust the dose of medication with the idea that the higher the dose of medication, the better the response of the ovary is going to be. And that works up to a point. Once you get to a point where you've got enough fertility drug floating around the system that the ovary is fully stimulated, it doesn't gain anything by adding more fertility drug. All the receptors on the ovary are plugged up. You're going to get the best response you can. And on a dosage basis, it correlates to between 450 and 600 units of medication. Now, if you're 25 years old with a very vibrant ovary, 225 units of medication is probably more than adequate. If you have polycystic ovaries, probably 150 to 200 units might be adequate. If you're 36 or 37, you may need 300 or 450 units. And if you're certainly 40 or above, you're going to need 450 units of medication to just get a maximum stimulation of the ovary. So we adjust the amount of stimulation that we need to based on all those ovarian markers that we spoke about, and most importantly, how a patient responds. If they've had previous use of these medications, we can use that response to modify what we're doing. If someone has never had these medications before, then we can select out what we think is going to be the best response to try and get to that 15 to 20 sweet spot. In simple terms, you're on fertility drugs for between 9 and 12 days. During that 2-week period, you have about 5 visits to look at the ovary and the hormonal response of the ovary to the medications. We adjust the medications as you go through the cycle to get the most ideal response. And then the second part of it is to do an egg retrieval procedure or oocyte harvesting. That's done with sedative anesthesia, which means there's an IV placed, intravenous line placed, and with some medications, same medications that are used when someone has wisdom teeth out or a colonoscopy type procedure. You're sedated so we can place by ultrasound a needle into the ovary and aspirate the lake of fluid that surrounds the egg and identify the eggs. It's very short-acting anesthesia. There is no need for intubation during this procedure. Most people don't remember much of it afterwards because of the medications, and after the procedure is done, patients discharged home usually about an hour or at most 2 hours later. When we get a batch of eggs, what we're going to find is that not every egg is a good quality egg, and a good quality egg is an egg that has reached what's called the metaphase 2 part of development, which means that it's ready to be fertilized. Eggs that are immature have not gotten to that point, and immature eggs, our practice is not to freeze them in our program because right now we don't have a really good way to turn those into mature eggs in vitro yet. That may change in the future, but at this point we focus our energy on cryopreserving the eggs that we know have a good chance of surviving the freeze-thaw process and can be fertilized at a later date. So not every follicle, which is the lake of fluid that we see on ultrasound, will contain a good egg, and not every egg that we get is going to be a good quality egg. But whatever eggs are mature are the ones that we cryopreserve, and we freeze them about 2 or 3 hours after retrieval. They're frozen by a process called vitrification, which is quick freezing or rapid freezing, and it goes from a liquid to a solid state instantaneously with this, and it's the one that has the best outcome as far as egg freezing. When you go to thaw these eggs down the road, not every egg that you froze is going to survive the thaw process. And statistically, if you look at large numbers of reports, about 15 to 20% of eggs potentially might not survive the freeze and the thaw process. So the more eggs we have to start with, the more eggs that we're going to have to potentially work with if we need to use them. If you need to use these eggs at a further date, it requires in vitro fertilization. So the eggs are thawed with a fine glass needle. You can inject a sperm into a egg, let those embryos develop, and then transfer the embryos. One of the options that's available if we're doing this is to do pre-implantation genetic testing for aneuploidy, which is to biopsy the embryo on the 5th or 6th day of development, send some of the placental cells on the outside of the embryo to a genetics lab, and tell us if the embryo has the correct complement of DNA, of the correct number of chromosomes present. Whether you produce embryos in vitro from an IVF scenario, or whether embryos form naturally on their own, a certain percentage of embryos just aren't normal. And this is a natural event. You have a normal egg and a normal sperm, you put them together, they make what looks like a normal embryo, but in the what are called meiotic division and multiplication of the embryo, it gets messed up and the cells are not normal. Now, what happens naturally to an abnormal embryo? Because they occur naturally. So everybody makes abnormal embryos at some point. If an abnormal embryo were to try and get into the uterus and implant, most of them just don't stick. They're programmed not to continue to develop. And if you put an embryo in there or it formed naturally, you'd probably get your period and the embryo, you'd never know you were pregnant or the embryo wouldn't work. The second most common thing that happens is the embryo can stick initially, but then because it's so genetically programmed not normally, it won't develop. So you wind up having a miscarriage, and most miscarriages occur between 6 and 10 weeks of pregnancy. If you collected that miscarriage tissue and sent it for genetic testing, you'll find that about 50 to 60% of all miscarriages, whether you're 25 or 50, 25 or 40 years old, most miscarriages are going to be caused by a genetically abnormal embryo, and it miscarried because it wasn't capable of developing. And then there are the rare abnormalities where you can get an abnormal birth because, like a Down syndrome, but that's age-related. You see that in 1 in 100 in someone age 40, 1 in 350 in someone age 35, and a much lower incidence in younger patients. So with pretty much 98% accuracy, you can tell whether the embryo will be affected or not by doing genetic testing, and that has the added advantage of selecting out the best embryo to transfer, particularly when there's a lot of embryos there. In patients that are 40 years old, or let's say if the eggs were 40 years old at the time that they were fertilized, that subgroup you're going to find 2/3 of the embryos to not be normal. On contrary, if you're looking at somebody who's 30 years old, it'll be the reverse. 70% of the embryos will be normal when they're formed. So that doesn't occur when you get the eggs, but it's something to think about when you go use these eggs. Freezing the embryos doesn't have any adverse effect in delaying their transfer, and you can, at the time you get there, one can address the issue is pre-implantation genetic testing, good for me or bad for me. Should I do it or shouldn't I do it? You don't have to worry about that right now. The big key now is making the decision: do you proceed with egg freezing to preserve fertility, or do you not? And that's a personal choice. And certainly my advice is the earlier you do it, the better. And we try and get as many eggs as we can. So how many is a good number of eggs? 5, 10, 15? Some of that depends on your age and what the expectation of these embryos are. If we work backwards from an embryo where, if you're close to 40 and 2/3 of the embryos aren't going to be normal, with the transfer of a normal embryo, you'd expect about a 50% to 60% pregnancy rate with a 10% miscarriage rate. So, you need 3 normal embryos to feel good that you got a decent chance of having one of them turn into a baby. So, if 70% of your embryos are not normal, you need 10 embryos to biopsy to have 3. If 30% of them are, then it's a lot different. You don't need 10, you need lot less. So how old you are will influence how many eggs you need to start with. But in general, for women that are 35 years or less that are cryopreserving their fertility with egg freezing, we estimate that 20 eggs frozen is going to give you a reasonable chance to have a baby from that batch of eggs, and possibly even more than one. But that's a good number. If you have 18, is that okay? It's probably pretty close. If you have 7 or 8, I would prefer you to have another cycle and batch your eggs, basically. So how many eggs can you get if you're, we try and get that 15 to 20, and if you're young with good ovarian reserve, often we can get that in a single cycle of treatment. If you're older and your ovary is very resistant to medication, then it's going to be a lot harder to get 15 or 20 eggs off a single cycle. And it's not uncommon in women that are 37, 40, 41. Sometimes you may only get 5 or 3 or 2, depending on how they respond. So then it becomes a question of, well, is it worth it to do it at all if I'm only going to get 1 or 2 eggs? And certainly it's a personal decision. The more eggs we have, the sooner one freezes one's eggs, the better the potential is down the road. So if you're young and you have good ovarian reserve, let's say you're 34 or 33 and you have good ovarian reserve, doing it now or 2 or 3 months from now probably isn't going to make a big difference. Doing it 2 or 3 years from now could make a very big difference. So one of the pitfalls that people fall into is that they're waiting for the ovarian reserve to drop to make the decision to preserve their fertility. But again, you want to do it before you reach that point, ideally, if you have the choice. Obviously, if it wasn't on the radar before, if it wasn't something you thought of before, there's no reason to go backwards or kick yourself in the butt because you didn't do it earlier. You just want to do it now and preserve whatever you can for the future. So we stimulate, we get eggs, we freeze the eggs, then we'll sit down with you and go over how many eggs do we have, is this a reasonable number, what are your goals? Your goal to have 1 child down the road or 2 or 3, and how much security do you want to have? And certainly age-related, 35 and under 20 eggs is a good number to have frozen. If you're 40, you probably need twice that many. If you're 40 years old, because of the high incidence of aneuploidy when these eggs get fertilized and turn into embryos, because it's the aneuploidy risk is over twice as high, you'd like to have twice as many eggs to work with. Once you have a normal embryo genetically, doesn't matter if you were 25 or 40 when that embryo formed, you get the same pregnancy rate from it. So you're better off having more eggs when you're older. They're harder to get when you're older, and hence coming back to the initial theory and recommendations that you want to do this earlier in one's reproductive life than later. The issue of how expensive is it to do egg freezing, it's a lot less expensive to freeze eggs than to freeze embryos, because we're not fertilizing the eggs, culturing them for 5 to 6 days, doing embryo biopsies, doing genetic testing, and freezing them. We're saving that whole second step for down the road at a later time. Egg freezing costs will vary depending on where you do it in the country. In our program, a first cycle of egg freezing is $6,500, not counting medications, and it's $6,000 for repeat cycles, basically. It's very competitive and probably on the less expensive side compared to if you went to New York, probably cost almost twice that amount. Medication costs are the other costs involved, and medication costs can vary on the low end, $4,000, and on the high end, $7,000, depending on the amount of medication you're using. So again, the big advantage here is if you freeze eggs when you're 32, and we can get 18 eggs with a limited amount of medication versus getting 6 eggs with a high amount of medication. If you just do the math and you figure out how much money it costs to get an egg frozen, it's much more efficient to do when the ovary is sensitive, vibrant, and producing good quality eggs, basically. The egg freezing itself, I think the package that we have includes anesthesia, the retrieval fees, all the monitoring, and freezing up to 8 eggs at a time. And then if there are a whole bunch of eggs beyond that, there's a small surcharge for each batch of 2 or 3 eggs. And we can, if people are interested in the detailed amounts, you can just contact our business office. We'll be happy to get you it in writing of exactly what it costs. But those are good ballpark numbers. The next question is, what do we need to know before freezing eggs? And we don't do a complete fertility investigation on couples because we're just freezing eggs at this point. And remember, the chances of getting pregnant down the road are going to depend not just on the quality of the eggs, it's going to depend on the sperm. And we can get around most sperm problems by doing ICSI when we fertilize the eggs. So sperm plays a role to some extent. The condition of the uterus is very important, and if one has fibroids or endometriosis in the muscle wall of the uterus, adenomyosis or scar tissue, or some anatomic reason why embryos won't stick as well, that will affect future fertility. If there are things that are predisposing to miscarriage, that could potentially affect future fertility, but those things don't matter right now. What matters now is how good are my ovaries, how do I make eggs, and how do I get these eggs preserved, basically. So what do we need to know? We need to know your ovarian reserve. That's from history. It's from doing some biologic markers, particularly AMH level, FSH and estrogen, sometimes helpful as well, antral follicle count, another thing that helps us figure out dosages. That tells us about ovarian reserve. Basic thing we need to know, blood count, chemistry panel. We need to know you're not anemic. We need to know that your basic chemistry, electrolytes are all okay. And most importantly, we need to know that your infectious disease screening, AIDS, hepatitis, and syphilis are negative. We do some cultures of the cervix to make sure there are no bacteria. We'll give you some antibiotics prophylactically in lieu of cultures to make sure that we're not putting you at risk by putting a needle into the ovary and aspirating eggs. We also check thyroid and prolactin levels on you. So it's some blood work, cervical culture, ultrasound, not overly expensive preliminary testing. Most of the preliminary testing is usually covered if you have testing for basic evaluation with fertility issues. Most insurance companies do cover basic evaluation. They don't tend to cover the treatment as well. However, a lot of Fortune 500 companies and companies that have tech companies and so forth have coverage. If you're a barrister at Starbucks and you have a full-time job at Starbucks, you have fertility coverage and IVF coverage. Apple and Google were one of the first companies to provide fertility preservation to all of their employees. So there's a lot of companies that do have it. American Express, I believe, has it. Some of the financial companies have it. And you just have to check your individual policy. If you have coverage for it, that's terrific. If you don't have coverage for it, then obviously it is pretty much what we alluded to earlier. And that's pretty much the whole story. In summary, the key is what freezing eggs does is it takes your fertility today and takes a picture of it, so to speak, and lets you use that picture of your fertility in the future. So it takes your fertility potential now and just transports it into the future for when you want to capture that fertility potential. Whether you use those eggs to get pregnant or you're trying your own at that point would depend on what your circumstance is when you want to go ahead and get pregnant and how many eggs you have frozen and what your long-term goals are as far as how many children you want to have. The testing that we need beforehand are just some infectious disease tests and tests of ovarian reserve and basic chemistry and blood count to know that we can safely get eggs without any problem. And that's pretty much it. It's not a complicated topic. It's just an issue of understanding where you are and making a logical decision. But if you're in your mid-reproductive years, if you're in that 30 to 40-year-old range particularly, and you are not actively pursuing conception now, not trying to get pregnant now with your partner, you really need to think about egg freezing. It's from a practical standpoint, you can't go back once the ovary has diminished reserve and wish that the ovary would work better. On the other hand, you don't want to beat yourself up for not doing it 5 years ago. You can only look at where you are now and going, okay, I want to capture this now and take it into the future. So that's the basic topic. I think we've covered fertility preservation with egg freezing, a little bit on ovarian reserve, a little bit on age-related aneuploidy and benefits of pre-implantation genetic testing. It all goes together in the same process of what happens as I age as a woman through my reproductive years, how does that affect my chances of having a baby, and how do I have a healthy baby in the future as well as now. So I appreciate everybody tuning in. Again, if there are particular topics you'd like us to respond to, please do. If there's any particular questions that don't get covered that you have, if you can text them while we talk, and I'll try and answer them at the end, or text them ahead of time and I'll address them as part of the conversation. So thank you for tuning in. Every Monday at 12:30 we're going to talk about something related to fertility. Often the subjects cover multiple topics indirectly, and thank you for being here, and we work hard to get you pregnant, keep you safe, and have a healthy baby. Have a good day, everybody. Take care.